go back to the list and some of the things that we look at potentially discontinuing in patients, I guess some common ones I would start with would be like a proton pump inhibitor or a NSAID, anti-inflammatory medication, because we know both of those are linked to some less than desirable long-term outcomes. And the data can be a bit messy because, sicker people are more likely to take more medications, but there's a very clear link between NSAID use, specifically chronic NSAID use, and kidney dysfunction, chronic kidney disease, increased risk of vascular events. And even if you're using a more selective, like a COX-2 inhibitor, as opposed to just slamming ibuprofen, you're going to still have that risk of long-term kidney disease. The proton pump inhibitors are a little bit more nuanced because some people are on those for very specific reasons. Barrett's esophagus, they've had some of those changes, so you're looking at, well, it's probably the lesser of two evils to continue on the PPI and reduce your risk for esophageal cancer, and then screen for those mineral deficiencies that we can see. So what are some of the common things you're screening for when you have someone on long-term proton pump inhibitor therapy?
You're screening for gut microbiome pathology. You're screening for osteoporosis, which is slightly more likely. You're screening for chronic infections. If they have inflammatory bowel disease, it appears a correlation but not necessarily causation. Theoretically it does, but it's not. It's a kind of a weak link between worse outcomes in inflammatory bowel disease like Crohn's and ulcerative colitis. Those are just a few of the things that you look for with chronic PPI use. If you're thinking about someone who's been on a PPI for a long period of time, often it's stomach irritation or heartburn or even silent reflux. And those are great cases to manage, often with a gastroenterologist, and also cases to consider testing for a bacteria known as H. pylori, which there's kind of a debate on whether or not it's a normal upper gut microbiota in extremely small levels. But if it gets severe, then it can even cause cancer.
Yeah, the H. pylori is certainly associated with the incidence of ulcers and then also long-term gastric cancers. But you were telling me about a paper that showed that a low titer or having some H. pylori actually may have some immunomodulatory properties, and we shouldn't just wipe out a bug because it's there in small quantities.
Yeah, upper gut and lower gut crosstalk. So your upper gut, I believe the upper gut in general ends at the ligament of Treats, which doesn't necessarily matter. It's just a tiny bit of the small intestine and then the stomach. Normally the stomach, at least classically, it was thought that the stomach does not have any normal bacteria. It's very acidic, or at least it's usually very acidic. And that's one of its, that's the body's defense mechanism. So when you lose that acidity in the stomach, you lose not only a lot of the body's natural defense mechanisms against things like fungi or bacteria, you also lose some of that kind of the top part of the enzyme cascade, where you're activating pepsin and a pepsinogen and basically just starting up all these different enzymes to help break down proteins and other molecules. In addition to that, if you look at the incidence of atopy, which is asthma, allergies, and eczema, a triad, you have a lower incidence if you have a higher titer of H. pylori, which is a benefit, and then you also have a lower incidence of ulcerative colitis and Crohn's as well.
Yeah, it's another great example of not wanting to be on one extreme or the other. You don't want to have a empty gut microbiome with no bacteria there. We know that causes problems, and at the same time you don't want to have overgrowth of other bacteria like the H. pylori or bacteria that are going to produce lots and lots of TMAO when you take in things like carnitine and choline. So really what I see is improvement in gut alpha diversity, which is the standard metric that they're using in these studies, seems to be correlated with positive outcomes. And there's a couple of behaviors we know that lead to this. Exercise is going to do it. You don't even have to take a probiotic to improve your alpha diversity. Eating fiber, which most people do not get enough of. Most people are, I think, about 10 or 15 grams per day, and they should really be closer to 30 or 40 grams per day. Slowly, of course. We don't want to give anybody abdominal discomfort. And then one that's come into the light recently is fermented foods. So things like ginger and sauerkraut and kombucha, lots of those fermented foods can improve the gut alpha diversity quite quickly.
Those are wonderful ways to help with your gut health. You see a lot of people start medications like a fluoroquinolone, like Cipro, even for traveler's diarrhea. And those are the ones that are not only associated with tendinopathies, they're also associated with the highest incidence of Crohn's and ulcerative colitis, and the worst outcomes when it comes to your gut microbiota. But that being said, there's a risk and benefit to everything, and sometimes you need it for a different reason. So it just goes to show that you need an individualized regimen when it comes to your medications and supplements, and also when it comes to your gut as well.
Yeah, I mean, that's a great point. You take antibiotics and, you are going to thin your herd quite significantly. And I think in the setting of antibiotics and the period thereafter, there can be some benefit for using probiotics or beneficial yeast like the Saccharomyces.
Definitely.
Particularly if somebody is prone to something like C. diff, which can be a life-threatening diarrhea depending on how frail a person is at baseline. But as far as somebody taking a probiotic every day, it's certainly not something I'm recommending for each and every one of my patients. Like, you have to take a probiotic. It's really a lot more about the lifestyle changes, because you see the benefits of probiotic therapy in a couple small studies here and there, but they do disappear fairly quickly after stopping that probiotic.
Yeah. Probiotics is an extremely interesting topic because, as we've chatted about before, there's a lot of over-the-counter, and now it looks like there's going to be prescription probiotics as time goes on as well. So how you patent a probiotic, not exactly sure how that goes on. Maybe you patent the delivery mechanism, but there's certainly a lot of companies trying to do so, and I have seen recent studies come out about certain probiotics and prevention of C. diff reoccurrence. They call it a full spectrum medication, or a full spectrum probiotic, but full spectrum is different in each person, so I'm pretty skeptical of whether or not they, if that's truly a perfect medication to give everyone.
Yeah, I certainly wouldn't prescribe it blindly for each and every person, but the trials I think I would like to see done there would be in these hospitalized patients who have either had C. diff in the past or who are in the ICU on lots of different antibiotics to get the appropriate coverage, and seeing what is the actual outcome here, because a probiotic should not really be that expensive to produce, and they're probably going to save money from preventing the complications of getting a recurrence of C. diff by putting people on this and putting the right patients on it. So not every single patient that goes into the hospital, but those that are screened and found to be at particularly high risk.
Yeah. I'd like it compared to other things, like S. boulardii is another interesting probiotic that's used often in gut pathology. So there's all these different ones, and you're tracking trends over time as well. One analogy that I like to use, no analogy is perfect, that's why they're called analogies, but you think of your gut, including your gut microbiome, as a very complicated combined terrarium and aquarium. Part terrarium, part aquarium. Things kind of live in the mix of both. And you can put in new species of fish or amphibians, but if you don't start feeding those fish and amphibians their preferred diet, they will just die out and die. So when you have bowel movements, let's say you have chronic constipation, imagine not draining the bottom of your fish tank. All that silt built up over time. That could be kind of like bacterial overgrowth. Let's say you have chronic diarrhea and just frequent stools, you're draining it all the time, and the good bacteria never has the chance to build up. And then you have other things like you mentioned, exercise, all the other factors that are related, even hormonal factors. That's like changing the temperature, changing the environment of your terrarium aquarium. So you have to change in order to help a probiotic work, or in order to keep those fish or amphibians alive that you want, then you have to change that ecological niche.
Yeah, it's a lot like nourishing a garden or taking care of an aquarium. You can't just throw the seeds or throw the fish in and expect everything else to work out. But talking about draining the system, I think that is a really good analogy for how some people are predisposed to SIBO. If you have a slower gastric motility, which happens with certain medications, happens as people increase in age, happens in things like hypothyroidism, you are more likely to see that bacteria from the large intestine back up into the small intestine, because that's what bacteria does to survive, is just proliferate and take the path of least resistance.
Yep.
And then those people, they can have this small intestinal bacterial overgrowth, which is correlated with a number of things, like restless leg syndromes, which then could be treated with, dopamine agonists as opposed to treating the SIBO that's causing the underlying issue. So that would be an example of somebody who has a medication with a interesting risk profile in the long term, but if we could treat the SIBO and then take them off of dopamine agonist over time, that would be another example of something I would look at as a unnecessary medication.
Absolutely. I had a commenter on one of my last posts, and he was saying these great insight about prebiotics and different foods to help your gut microbiome and probiotics. And I read his name, and it was Steve Laureus, and I was like, that's a famous aesthetic bodybuilder. I thought to myself, it's no coincidence that a bodybuilder who is most known for no gut bloating and being extremely aesthetic, no bodybuilder gut, and just like a great midsection, is caring about these things. So it matters for aesthetics as well.
Yeah, it's more than just people who want to be, health nuts. If you were in the summer and you just want to be less bloated, there's a million hacks out there that, will claim to de-bloat you, but it's really about building a healthy, gut foundation from the ground up, because you can be very lean, but if you've got, a bunch of gas expansion going on in your intestines, you're going to look bloated and you're not going to see the results of your hard work for summer.
So there's more to it than just pineapple, apple cider vinegar, and low FODMAP.
And detox teas.
And detox teas too.
That's right.